Good morning, everyone. Thank you for your patience as we allowed time for people to move from the waiting room into this presentation. My name is Jay Benz, and I am the Director for the Office of Licensing. And on behalf of the Office of Licensing, I want to welcome you to our Quality Improvement, Risk Management, and Root Cause Analysis training. Today, we are going to go over the data we have collected from the inspections we completed in 2021 related to providers' compliance with quality improvement, risk management, and root cause analysis regulations. And then we are going to review what to expect during our unannounced inspections in calendar year 2022.
Thank you, Jay. This is Deborah Vogt, and we do appreciate everyone joining us this morning. We do ask that you please post your questions in the Q&A box because the chat function is disabled. This webinar is being recorded, and the presentation, the recording, and the FAQs will be posted to the Office of Licensing webpage. So as Jay said, we are going to review developmental disabilities providers' compliance with the following regulations: risk management, quality improvement, and then root cause analysis as it relates to 160E2, which is that the provider have a root cause analysis policy. Then we're also going to review some issues that were identified when providers were not compliant. And we'll remind providers of available resources, which may be helpful to you. And then we also are going to review what documents will be requested as part of the annual inspections. So for the third year, the Office of Licensing will be issuing an annual inspection checklist. The licensing specialist will be evaluating compliance with a number of regulations during the annual unannounced inspections. And a list of the minimum regulations that will be reviewed, as well as the criteria for achieving compliance, will be shared over the next few weeks. And then in addition, your licensing specialist will review corrective action plans that have been submitted since the last inspection to determine if those corrective action plans have been implemented as approved. So let's begin with the next slide, which is that DBHDS's efforts to achieve compliance with the Commonwealth Settlement Agreement with the U.S. Department of Justice includes what are called agreed upon indicators. This slide includes one of those indicators. So the Office of Licensing collects critical information related to DD providers' compliance with all of the risk management regulations. So in a way, this is one of DBHDS's measurable goals. So the next slide shows that the percent of licensed DD providers that met 100% of risk management requirements was at 61%. Our goal again being 86%. And the data though is from January 1st to September 30th of 2021. And throughout this presentation, I will be referring to data for that time frame, January 1st to September 30th. And I will highlight in red those where we did not meet our 86% goal. So let's begin with 520A, which is on the next slide. And that is that each provider shall designate a person responsible for risk management function who's completed specific training. I'm not going to read that whole regulation, but you should refer to 520A. And so our compliance for that regulation fell below our 86%. It was at 76%. So I remind providers here that in early 2021, DBHDS issued the crosswalk of approved training and the attestation. And the crosswalk included each of the topic areas and the training that qualified for each topic area. So on the next slide, you will see some of the identified issues. Providers were cited for failure to submit a completed risk management attestation. Others did not submit the job description for the person responsible or designated for risk management function. Others did not complete the training that was on the crosswalk as approved. Others failed to sign the attestation. And I remind you that by signing the attestation, providers attest to the fact that the risk manager participated in either the live webinar or reviewed the training presentation online. And the document is to be signed and dated by the person designated as the risk manager and the person's supervisor. So for example, if a provider has a change in staff, someone resigns or changes responsibilities, the person assigned the risk management function, as evidenced by their job description, would need to complete the training and complete the attestation. And that completed attestation should be kept on file and then available upon request by the licensing specialist. So if you hire a new person, you need to complete the training and complete the attestation, and that person's job description should reflect this responsibility. Now, we updated the attestation in August and posted it to the Office of Licensing webpage because we included additional information about the Office of Human Rights training on conducting investigations. So if we look at the next slide, we can see an example of one that was not acceptable. The provider did not accurately complete the attestation. All topic areas should be completed, as well as the date the training was completed. So it's important to read those instructions that are included in the crosswalk and the attestation. So it's not clear what training the risk manager took for each of these topic areas. But if we go to the next slide, we will see one that was completed correctly. In this example, the staff member watched the CDDER recorded webinar, which is on the Office of Licensing webpage, and they even attended a training that we did in June. And then later, they watched the Office of Human Rights YouTube video on conducting investigations. They completed it and they put the date on which they completed it. I'm also mentioning here that the Office of Human Rights has issued a training calendar for 2022. So if a provider wants to participate in a live webinar rather than watching the YouTube video, the information about that is available. And our crosswalk includes the hyperlinks to these trainings, so it is easy to access them. So for the next slide, we see that the attestation will be requested again in 2022. So all topic areas should be completed, the dates of the training. Again, read those instructions, but make sure it is up to date with the information because perhaps previously your risk manager had not completed the Office of Human Rights training. It needs to be done. And I included here in the blue box what is on the attestation form. It is saying that by signing the document, the risk manager and the supervisor are attesting to the fact that the training has been completed. Now, if the person responsible for risk management is the owner and does not have a supervisor, this should be noted on the document. We can go to the next slide then, which brings us to 520B, which, as you know, is about implementing a written plan, a risk management plan. So we are to have a written plan to identify, monitor, reduce, and minimize harms and risks of harm, including personal injury, infectious disease, property damage or loss, or other sources of potential liability. In this case, it's green, it's 88%. But I am going to highlight on the next slide just a couple examples of how the providers were compliant if their plan included how they were going to identify risk, how they were going to monitor those risks, and how they would attempt to reduce and or minimize. So the next slide gives a reference to the sample document, which we posted on the Office of Licensing webpage back in June. And we gave some examples, and these are just examples of how you might do that. You identify risks through your systemic risk assessment, through safety inspections. How do you monitor it? Well, you review serious incident reports. You have your leadership review trends. You're looking for that convergence of data, which is when you identify that there's been an increase in serious incidents at the same time that there's been an increase in staff turnover. You're looking at your care concerns. And then how are you going to reduce and minimize? Well, conduct a root cause analysis, propose an initiative to minimize risk. So these were just some examples that, and they are again included in that sample document. And the next slide takes it a step further though to remind everybody to really read the regulations and refer to the guidance documents, but it's several things. It's personal injury, infectious disease, property damage or loss, and other sources of potential liability. So all of that needs to be in your risk management plan. So let's go to the next slide, which is again about the 2022 inspections. I am mentioning a caution here. If you are using templates issued by DBHDS prior to the implementation of the regulations effective August 2020, please review that document closely to make sure it is compliant with the current regulations as well as agency requirements. And again, we issued a new sample risk management plan in June of 2021. So the next slide gives you an example of what that previous template included. So this was the medication events, it says, as highlighted in yellow there, DBH defined triggers and thresholds, for example. So DBHDS has defined risk triggers and thresholds as care concern. So these may not be exactly consistent with current agency requirements. And that's why we're encouraging people to please carefully review anything that you use prior to the new regulations, which were effective in 2020. So for the next slide, we say in 2022, again, we will be asking for the risk management plan. And so you need to prepare, make sure the plan includes all the components outlined in 520B. And remember, it's a plan, it's not a policy. Pursuant to the guidance for quality improvement program, the risk management plan can be part of the quality improvement plan, but we do encourage you to designate it as such, perhaps identify it with a header. So we'll move on to the next regulation, which is 520C. And this is about the systemic risk assessment, which must be completed at least annually. Again, this is the whole regulation. So I will not read this. I would encourage you to certainly read them. But if we go to the next slide, we're going to break it down by each of these elements, which must be included in the systemic risk assessment. So the first one is environment of care. Some of the issues that we identified here was that first off, the provider just did not have a completed systemic risk assessment. Providing a form, a blank form, does not meet compliance. Others provided just their safety inspection. And so we want to be real clear that environment of care there's a whole lot that's incorporated in that. It will depend on the provider's location, their building or buildings. Each provider needs to think about its environment of care and the potential risks. So then we can move on to the next slide, where again in June, we did post a sample systemic risk assessment. And we did training on this as well in June 2021, and that PowerPoint is posted. But this is just one page out of the 12-page document. But again, it shows that environment of care and how you would be conducting your systemic risk assessment to look at what you identify, what recommendations you're going to make, whether you're going to add it to your risk management plan, maybe who you're going to assign it to. You do not have to use this specific format, but we are giving it as a sample. So we'll move on to the next slide, which is C2, which also needs to be in your systemic risk assessment. And that is clinical assessment or reassessment processes. This was at 80%. And some of the identified issues here were the same. Either people did not have a completed systemic risk assessment, or they did not include clinical assessment or reassessment processes. So what does that mean? So the next slide gives us an example. So when the annual systemic risk assessment is conducted, a provider says there have been an increase in falls. So they may review whether their reassessments were being completed, identifying risks unique to the individual served. And as they do that, they note that the policy was not being implemented consistently. So the provider identifies this as a risk on their systemic risk assessment. And the risk management plan could then be revised to include how this will be addressed. So I also did a visual on the next slide that kind of shows how it might come together. So throughout the year, the provider is reviewing their level 1 serious incidents on a quarterly basis, and they see an increase in falls. So when the systemic risk assessment is completed, the provider is asking, is the reassessment process identifying all the individual's risks? For example, people age and they may have issues that relate to more falls, or they're presenting with new risks related to falls. So if the provider considers this to be an area of risk, they include this in the risk management plan. And they perhaps review their policy or implement more audits of their reassessments to make sure they're being done in accordance with their policy. So we move to the next slide, which is also part of your systemic risk assessment. This came in at 80%, again, noting for that time frame. But this is the risks related to staffing. So, you know, there's a lot. Employees have to meet minimum qualifications to perform their duties. They have to complete orientation. They have background checks. All of these things are risks. So on the next slide, what we found was some providers didn't include all of that in their systemic risk assessment. They either didn't complete one or they didn't include reference to competence and adequacy of staffing. So here's an example. The provider might ask some questions such as, what was the staff turnover rate? What issues impacted the staffing plan over the past year? What are the provider's risks? And then how does the provider attempt to reduce or mitigate those risks? So the next one is also part of your systemic risk assessment, and that's the use of high risk procedures. And that was even lower at 79%. Again, same problems, they didn't complete it or they didn't include high risk procedures. So on the next slide, we talk about what that should include. So it's not just seclusion and restraint. It could be administration of high-risk medications, high-risk methods of medication administration, transfer of individuals. There's a whole lot that could be considered high risk depending on the population served. So on the next slide, we say, based on those, then you consider, are you following the laws and regulations that govern the use? Are we reviewing procedures to determine whether they're still appropriate? Are staff who are implementing them qualified to do so? So those are all things that we want to include when we're doing that C4, that part of your systemic risk assessment. Then we move to C5, and that is review of serious incidents, which was at 84%. I think the identified issues we saw here related to failure to review for patterns and trends. So let's go to the next slide and do a little bit of reminder here about the review of serious incidents. So 160C says that the provider shall collect, maintain, and review at least quarterly all serious incidents, including level 1 serious incidents, as part of their quality improvement program in accordance with that 620, to include an analysis of trends, potential systemic issues, indicated remediation, and documented steps to mitigate the potential for future incidents. So again, all of these regulations tie together. So your systemic risk assessment should really be identifying the incidences of common risks and conditions that occurred. And for DD providers, this would focus on common risks for individuals such as decubitus ulcers, UTI, aspiration pneumonia. So when you're completing your annual systemic risk assessment, you're looking at your incidents for trends and patterns. So in this little simple chart that's made up data, we would just say, well, look at that. There's been an increase in aspiration pneumonia. And if so, then that's a risk. And that should be addressed in our risk management plan and or as part of our quality improvement program. So when it comes to serious incidents, I break it down real easily on the next slide. For me, you're looking at them as they occur. So that is real time. At least quarterly, you're reviewing all of them. Your level 1s, 2s, and 3s, and you're identifying patterns and trends. Annually, as part of your systemic risk assessment, you're including all of that data. So your risk management plan or your quality improvement plan includes documentation of steps to mitigate the potential for future incidents. So let's, again, a simple example. A provider reviews all their SIRs quarterly, and they see an increase in choking incidents. Now, some of the incidents did not result in a level 2. And just a reminder that a level 2 for a choking incident would involve direct physical intervention by another person. But the provider identified this as a potential risk, and they decide to prevent and or mitigate future incidents as much as possible. So they review their risk management plan, they conduct a root cause analysis to determine why there's all of a sudden been this increase in choking incidents. And then based on that, perhaps they revise dietary protocols. There are many things that they could put in place, but this was just an example to show how you're looking at it all the time because you're trying to constantly attempt to mitigate or reduce potential harm. For the next slide, I'm going to turn it over to Michelle Laird with the Incident Management Unit, and she's going to provide some information about care concerns.
Good morning. Thank you, Deborah. So today I'm going to be looking at 520D, which discusses risk triggers and thresholds. And that is defined as the systematic risk assessment process shall incorporate uniform risk triggers and threshold as defined by the department. And as you can see, the compliance score for that is 78%. But we do want to look a little closer at what care concerns are. So if we go to the next slide. So the department does define risk triggers and thresholds as care concerns. The care concerns were revised in October of 2021. There is a memo that includes that information, but we did want to revisit that today and just discuss that a little more. So currently there are two care concerns identified by the department. The first one is multiple, 2 or more unplanned hospital visits for a serious incident, including falls, choking, urinary tract infection, aspiration pneumonia, dehydration, seizures within a 90-day time frame for any reason. The second care concern is any incidents of decubitus ulcer diagnosed by a medical profession, any increase in the severity of the level of a previously diagnosed decubitus ulcer, or a diagnosis of a bowel obstruction diagnosed by a medical professional. So we did notice that those who got care concerns did not have those documented within their plans. So if we look at the next slide, we'll go over some of the identified issues. So providers who had care concerns were cited if there was nothing in their systematic risk assessment regarding how they address such care concerns in their risk management process. Some providers did not identify the risk triggers and thresholds as their care concerns. So if we look at the next slide, we're just going to touch base on the incident management unit's role with regarding care concern thresholds and how those are identified. So the incident management unit reviews serious incidents, not only on an individual level, but also systematically, as well to identify past possible trends and patterns by the individual, a provider's licensed service, and across providers. So through this review, the incident management unit is able to identify areas based on the serious incidents where there is potential for risk for more serious outcomes. So when care concern thresholds are met, it may be an indication that providers may need to reevaluate an individual's needs or support. They could also review the results of the root cause analysis, or even consider making more systematic changes. And in the past, we have emphasized that having a care concern identified does not mean that a provider has done something wrong, but this is a tool that is to be utilized that the department is offering. There are reports available in the CRIS system that can be printed by the provider, and hopefully you will take advantage of those tools and use those for your assessments. And Deborah, I'll turn it back over to you.
Thank you, Michelle. So for the next slide, we see that for 2022 inspections, that systemic risk assessment will be requested. So you need to prepare. If you have one in place already that's working for you, great. Otherwise, you may want to review what we have posted on the web page, determine the best format for your organization, and think about your risks. And then make sure that you're reviewing the regulations to make sure it includes all of C1 through 4 and 520D. So it's not a blank checklist, and it's not a policy that you say, we're going to do this. This is a systemic risk assessment that is completed for your organization. And it is about your organization, not about risk assessment for individuals. And then the next regulation is on the next slide is 520E, and that is that the annual safety inspection, at least annually for each service owned, rented, or leased by the provider. And for this, we at 90%. So just reminding them again that that is all included in these regulations. So the next slide for me is just kind of a transition point to 620, which is about quality improvement. But I put it here to remind everyone as a visual that there is a relationship of all of these regulations, whether we're talking about systemic risk assessment, risk management plan, root cause analysis, or quality improvement. The central idea is to improve the provider's processes and outcomes for individuals served. So it is all connected. And then that brings us to the next slide, which is about 620, and that moves us to quality improvement. And for 620A, which is that providers have a written procedures or policies for a quality improvement program, the compliance was at 90%. However, I want to remind providers on the next slide the difference between a program and a plan. So your program is your structure and or foundation for your quality improvement program, right? It's policies and procedures that include 620D, which we will go over later. It may include the quality improvement tools that you use. But your plan is a work plan or roadmap for the year, and that includes your goals. So just emphasizing that again, and then we'll move through all the rest of the 620 regulations. So the next slide has 620B, which is that the program shall utilize standard quality improvement tools, including root cause analysis, and shall include a plan. And that was at 88%. And remember, there are lots of quality improvement tools, not just root cause analysis. So make sure you include those kinds of things like your plan, do, check, act, or your aim statement, all of those different types of quality improvement tools. And so then we go on to 620C, which is that the plan shall be reviewed and updated at least annually. Now, we did not quite make our 86% there. I put this calendar here, but to remind providers that the plan can be calendar year, fiscal year, whatever is appropriate and works the best for your organization. So the next slide shows what we found, that some of the reasons people didn't meet compliance was they did not date the plan. So this is necessary if we're going to demonstrate that the plan was reviewed and updated at least annually. Next, a policy is not a plan. So copying the regulatory language, that's not a plan. So we have issued a sample quality improvement plan. It's just a starting point for providers to look at, and the training that we did in June. And that sample document is again posted on the Office of Licensing webpage. But please be careful and mindful of the fact that this is separate from your program. This is your plan. The next slide for C2 says that that quality improvement plan shall define measurable goals and objectives. This was at 77%. And I encourage providers here to think about what you might already be doing in terms of writing goals. You're writing goals for an individual support plan or a treatment plan. You might utilize some of those same concepts for writing your organization's quality improvement goals and objectives. And of course, there's always the SMART: specific, measurable, attainable, relevant, and time-bound. So what did we identify? Well, we'll look at the next slide. We will see that a lot of providers struggled with getting what was truly a measurable goal and objective. So for example, provide a safe environment. That's a good goal, but it's not measurable. So reduce the rate of level 2 serious injuries by a certain percent by December 31st. That would be a measurable objective. So if you knew what your rate of level 2 serious injuries were for the previous year, you could say, we want to reduce that. I would remind you also that there is no requirement for the number of goals and objectives. So really think about measurability and writing it in such a way that you can measure it. So we move to the next slide, which is 620C3, and that is that the quality improvement plan shall include and report on statewide performance measures as required by DBHDS. This regulation was non-determined this year because we said that this would only apply to providers of developmental disability services, and that we were going to operationally collect through WAMS and CRIS. As this changes in the coming years, we will provide additional information and people will be informed of it accordingly. So we move to 620C4, and that is that the quality improvement plan shall monitor implementation and effectiveness of approved corrective action plans. This also was low at 74%. So let's look at some of the identified issues. Either providers had corrective action plans and they had not reviewed in terms of with their QI plan, and they hadn't determined whether it was sufficient to address the concerns identified in the licensing report and to monitor compliance with their CAP. Or if they decided not to update their QI plan, there was no documentation included in their meeting minutes or as an addendum to the QI plan. So I tried to put out a couple examples on the next slides of how this would work. So this is kind of how the process works, right? A provider is cited for failure to conduct fire and evacuation drills at least monthly, pursuant to that regulation. They get their corrective action plan. They say they're going to have a revised process to ensure 100% of fire drills will be completed monthly. And then they review their QI plan and they say, you know what? Let's update the plan to include this goal, make sure we're monitoring it on a monthly basis to make sure that whatever we put in place pursuant to our corrective action plan is effective and that we sustain this compliance. So that's one way it could work. On the next slide, the decision is different. A provider is cited for failure to have a root cause analysis policy pursuant to that regulation. Their corrective action plan, they're going to develop an RCA policy with thresholds appropriate to their organization. They review their plan and they say, you know, we already have a goal related to SIR reporting and we have something related to root cause analysis. So they do not decide to update the plan. They document this decision in meeting minutes, and therefore they have documentation of their decision. The next slide is C5. And so this is the quality improvement plan shall include ongoing monitoring and progress toward meeting established goals and objectives. This was at 78%. And it's important to review and respond to data. That's what quality improvement is all about. And so that's why your goals and objectives need to be measurable in order that you have data to monitor. So the next slide shows the identified issues. Providers didn't have measurables and objectives, so there was no data to monitor to show progress. So what this means is that their ongoing monitoring should be either data as an attachment to the QI plan, could actually be right in the QI plan, or you have meeting minutes where data is presented and you can show that you're reviewing it. So I tried to give an example on the next slide of how that might work. So a provider says, we have a goal that new employees receive required orientation. And this is their measurable objective. By December 31st, 100% of new employees, contractors, volunteers, and students shall be oriented in all required policies, procedures, and practices within 15 days of hire. Now, this is just a sample, an example to demonstrate how you might monitor it. And I'm very clear here that this sample does not include all required training pursuant to Regulation 440, because it's certainly more than human rights, infection control, emergency preparedness, and person-centeredness. But those are the four things I included on this chart. So this is how they're monitoring it. They say, January, here's the training. We had 5 new employees and they were all trained within 15 business days. So that's great. February is great. Then on the next slide, we see March comes along. They hired 8 new employees and only about half of them got to the infection control training. Only half of them completed the person-centered training. So again, the whole purpose of collecting and reviewing data is to see if you're making progress toward that goal or objective. So in this example, they did well maybe for a couple months, but then all of a sudden there's a dip in compliance. So the provider has to ask questions as to why did this happen? Perhaps it's just they were there, but the documentation is missing, or the training schedule isn't working. So then they have to take action to try to address that and demonstrate how they continue to monitor progress. So ongoing monitoring needs to be demonstrated somehow. So we go to the next slide for 620D. And this is about that the provider's quality improvement policies and procedures shall include the criteria they're going to use to do all 3 of those things. So this is to be part of their quality improvement program. I'm not going to read all of that, but I would encourage you to do so. But let's look at the compliance on the next slide. So for D1, it was 74%, D2, 74%, and D3, 65%. So we're going to break this down on the next slide. I think the main thing was that providers just did not decide and outline in their policy what their criteria was going to be. They just copied and pasted regulatory language, but that does not establish the provider's criteria. So this is Webster's definition of criteria. It's a principle or standard by which something may be judged or decided. So I would really think about that. It's a standard by which you're going to decide something, if that helps. So let's break this one down and look at some examples. For D1, you know, there's a whole lot that leadership and an organization can say, we have all these ideas for goals and objectives, and you can't do everything. So your criteria help you prioritize what the provider will establish as a goal and how they're going to measure it. So these are some examples, and you wouldn't need all of these, certainly, but you might think about these and think about what's important to your organization. So you could say, you know, we're going to measure, we're going to establish our goals and objectives based on what we think will really improve outcomes for individuals served. Or we're going to establish measurable goals and objectives on areas of high risk. We're going to base it on what we get from our customer satisfaction surveys. So there are lots of things, and we're just providing some examples to consider. For me personally, I think the main question is, what do you really care about? So what do you see as the priority that you need to set as a goal and objective? And include that kind of criteria in your policy or procedure. We move to D2 on the next slide. This is about then your criteria for when you're going to update the quality improvement plan. And again, every provider needs to decide what is most meaningful to your organization. You may say that you're going to certainly update it at least annually, but you may also say whenever you have a change in service, whenever a new goal is developed, there could be all kinds of things that you would add. D3 on the next slide is about when you're going to, the criteria that you're going to use to submit revised corrective action plans. Again, I won't read all of that, but this is about your caps and whether what criteria you might use. Again, we're giving you some examples on the next slide. You may wish to revise the cap if you see progress is not being made to correct the deficiency after so many months. So you've put something in place and within 4 months, if you're not seeing improvement, you might say, we need to revise our corrective action plan. Or you're always going to do a root cause analysis, or you're going to monitor and then identify additional measures to address. So, you know, once your cap is implemented, but no improvement, then you need to be asking yourself, well, are we following our policy for when we're going to submit a revised cap? What is the criteria we're going to use for doing so? So for the 2022 inspections, the licensing specialists, again, will be looking at your quality improvement policies and procedures to include this. So make sure that criteria are outlined and they're appropriate for your organization. Avoid copying and pasting the regulatory language. And you can't just say, well, the committee will establish the criteria. I think it's very important that you actually outline it in your policy so that everyone understands this is what we're following. So we'll move now to 620E, which is about customer satisfaction. This regulation came in at 80%. Many people have put things in their program, in their policies and procedures, but we need to take it a little step further, and we'll look at that in the next slide, where we say the identified issues were that they included it, but there was no proof of it. So if you're not going to use a survey, there at least should be documentation of how that customer satisfaction was obtained. So again, for the 2022 inspections on the next slide, that's what you need to be prepared for. How are you obtaining input? And then, you know, even consider, so what are we doing with this? We get these results, so how are we implementing this? A licensing specialist may ask, how are you obtaining it? How is it documented? What's being done with the results or the findings? If a provider gets a lot of feedback related to a specific concern, is the provider addressing this then? Is it a quality improvement initiative or a new goal or objective added to the quality improvement plan? All of that feedback should be helpful in directing the provider's quality improvement efforts. So finally, we get down to root cause analysis. And again, we are only going to be talking here about 160E2 A through D, which relates to a root cause analysis policy that the provider must have for determining when they're going to do a more detailed root cause analysis. So on the next slide, we have the compliance. Many people had a policy, but in some cases, they did not identify what that threshold was going to be. So that is why E2A, maybe 65%, 2B, 72, 2C, 65, and 2D, 74%. So let's look at the identified issues. Some people didn't have a root cause analysis policy at all in terms of when a more detailed one would be conducted. And then another issue was that providers copied and pasted the regulatory language. And so in doing so, they copied a threshold number. That threshold number needs to be determined by the organization. So cutting and pasting does not work into your root cause analysis policy. So for 2022, on the next slide, again, this policy will be requested. So to prepare, you should review your RCA policy and make sure it is in compliance with the final DOJ regulations, and make sure you are determining that threshold number for more detailed root cause analysis. I would add here that the RCA policy may be included in your serious incident policy. It does not need to be a standalone policy. So for the next slide, we tried to kind of summarize some of the documents that will be requested as part of the 2022 inspections. Certainly, this is not all inclusive because there will be documents related to other regulations. And again, the Office of Licensing will issue the inspection checklist in the coming weeks. But for 520, it's that risk management attestation, the job description for the employee responsible for the risk management function, your risk management plan, your systemic risk assessment. For 620, it's the policies and procedures that make up your quality improvement program, and then your quality improvement plan, and then proof of how you're obtaining input from individuals receiving services and authorized representatives, if applicable. And then for 160E2, it is that root cause analysis policy. So those are the things that we've gone over. So for the next slide, I wanted to just highlight again, since I referenced it several times today, this is a snapshot of our webpage where we have some resources that might be helpful. We have the attestation and the crosswalk, previous trainings, sample documents. So all of those things are out there, and we would encourage you to review those. And in those, you will often see also hyperlinks to other resources. And I would encourage you to review those as well. And then the next page is the guidance documents. And that also is on our webpage. And it's really important to review that because it kind of helps you with breaking down each of the regulations. And I'm on the next slide saying that we are also going to be issuing a sample root cause analysis policy and a quality improvement program policy. So those are some new resources that will be coming soon. So please keep referring back to the Office of Licensing webpage, and we put all of those under that specific section related to QI-RM. On the next slide, I also have the Centers for Medicare and Medicaid Services. They have a quality assurance performance improvement framework and includes some really great resources for how to set goals. There's also the Institute for Healthcare Improvement, IHI, and they have a quality improvement toolkit that's very user-friendly. So there are lots of resources out there. So we encourage you to use those as much as possible. So I think at that point we may put you on a brief hold. We do have a couple questions we want to ask of you. So I'm going to launch this poll because we want to know what's helpful to you. And you can go ahead, I hope that worked. You can go ahead and answer those questions. They're single choice. And then while we're doing that, I would ask that we are going to just take a brief second. We'll put everyone on mute, and we're going to be looking at the Q&A that we've received and see if we can answer some of those questions for you now.
Everyone, good morning. My name is Emily Bowles, and I am the Associate Director for Licensing, Regulatory Compliance, Quality, and Training. And I'm going to go over some of the questions that we received in the Q&A today. I want to make a couple notes that we received a few duplicate questions. Some questions were asked several times, so we're just going to answer those questions one time. So if you don't hear your specific question answered, but it's the same general question, that's the answer that we're going to give. In addition, we received several questions asking about if a copy of this presentation would be available. Yes, we will be sending out a copy of this presentation via our Constant Contact this afternoon. It will also be available on our website. If you do not receive our Constant Contacts, we highly, highly encourage you to sign up for them. You can find the link to sign up for Constant Contact on the Office of Licensing website. And the vast majority of Office of Licensing staff also have the sign up link in their signature lines. So please make sure to sign up for Constant Contacts, because that's how you will receive copies of the presentations that we give directly, as well as memos that include important information. And yet, actually, I'm just going to put the Constant Contact sign up link in the chat directly as well. So if anybody isn't signed up for the Constant Contact, you can go to this link right now and sign up. And you can also share with any of your coworkers as well who might not have access. So we received a question whether or not this presentation was only for providers of developmental disability services. And we also had some providers of different services asking when they would get training related to their specific service. So this particular training includes data specific to providers of developmental disability services as it relates to the DOJ settlement agreement. However, providers of mental health, substance abuse, and brain injury services are responsible for being compliant with the licensing regulations during this training. A copy of the guidance documents related to the Office of Licensing regulations can be found on the Office of Licensing website, and these are applied to all services. So the licensing regulations, with the exemption of a few, including the ASAM regulations, apply to all licensed services. So although the training includes data related to developmental services, the regulations apply to all services with the exemption of children's residential services. So someone asked, do we only have to do this training once, or is it yearly? Do we need to sign the updated attestation form since it was signed prior to August 2021? The training only needs to be completed by the risk manager once, unless the provider was found to be non-compliant with risk management or root cause analysis requirements for reasons that are related to a lack of knowledge. In that case, the provider may be required to demonstrate that they have completed additional training offered by the Commonwealth as part of their corrective action plan, also known as their CAP. By signing the attestation, providers attest that the risk manager participated in the live webinar or reviewed the training presentation online. The document is to be signed and dated by the person designated as the risk manager and that person's supervisor. If the provider has a change in staff, the person assigned to the risk management function would need to complete the training and complete the attestation. The completed attestation should be kept on file and available upon request by the licensing specialist. So for example, the risk manager resigns and the organization delegates another staff member to be the risk manager or hires a new person. That staff member would need to complete the training and complete the attestation. That person's job description should also reflect the risk management responsibility. The crosswalk was updated in August of 2021 and was posted on the Office of Licensing website. I know that we received several questions about the Office of Human Rights training on conducting investigations, and that is the link to that is also included within the August 2021 crosswalk, which is on the Office of Licensing website. So Related to the attestation, we received a question that said, if a new person is hired and the risk manager and completed these trainings while working at a previous job, will it be acceptable to have a copy of that form in the personnel file at the new place of employment? A provider may accept a completed / signed attestation from another provider if their risk manager completed this the training attestation while working for another provider. However, the current supervisor would sign / date the attestation indicating review and approval of that already completed attestation. So if you hire a new risk manager that came from another provider organization and already had the attestation signed, you would want to review it as their new supervisor and ensure compliance with the regulations. And then you would just want to indicate your review by signing and dating that attestation as well yourself. So yes, we will accept signed attestations from another provider for new staff, but as the new employer, it is your responsibility to review and to make sure that the form was completed correctly and to sign off to indicate that you did complete that review. Someone said, are we supposed to complete the new updated attestation if we completed the original version? When in 2022 should the updated attestation be completed? If your current attestation includes proof that all required trainings were completed and your risk manager remains the same as last year, the attestation does not need to be updated. If you did not include a documentation of the human rights training on your attestation from last year, then your attestation should be updated to include proof that all trainings were completed as required. This should occur as soon as possible. Once again, I just want to mention that the crosswalk was updated in August of 2021 and posted on the Office of Licensing website, which includes the link to the human rights training on conducting investigations. So if the attestation form included all required trainings from last year, it does not need to be updated this year. We received a question about whether or not the attestation needed to be written or typed. It can be either typed or handwritten. There is no requirement for one way or the other. We received a question that said, how long after a hire is a risk manager supposed to have the trainings completed? The regulations do not specify. Regulation 12 VAC 35-105-440, also known as Regulation 440, states that new employees, contractors, volunteers, and students shall be oriented commensurate with their function or job-specific responsibilities within 15 business days. The provider shall document that the orientation covers each of the following policies, procedures, and practices. If you have an employee that transitions to the risk management position, they must be oriented commensurate with their job-specific responsibilities within 15 business days. So that's 15 business days or 3 working weeks. Someone wrote, where do you find the attestation? I will copy and paste the link right now and include it within the chat for anybody who does not have a copy. Once again, this is linked on the Office of Licensing website, but here's the direct link as well. So we received a comment that says, often multiple unplanned hospital visits occur because a hospital prematurely discharges despite our advocacy, and when the individual continues to need medical attention and we take them back to appropriately seek care, it seems we are dinged for doing exactly what we should be doing. We are often answering for the hospital's lack of appropriate care. Are these conversations happening about how to better join providers in advocacy for appropriate medical care rather than always approaching them from a care concern perspective? So first of all, we wanted to thank you for sharing your concerns and for bringing this to our attention. When care concern thresholds are met, it doesn't mean it is, but it may be an indication that a provider needs to reevaluate an individual's needs and supports, review the results of the root cause analysis, or even consider making more systemic changes. However, The Office of Licensing realizes that providers who take individuals with higher needs may have a higher number of incidents. Therefore, just because an incident meets a care concern threshold does not mean that a provider is not doing what they're supposed to be doing or that the Office of Licensing has concerns. We have said it before in several other trainings, but just to reiterate, as we've stated before, serious incident reports are in no way punitive. Please feel free to contact our office directly with additional systemic concerns. In addition, the provider organizations are a great mechanism for joining providers together for system-wide advocacy as well. We received a question that said, can the systemic assessment be added to the quality improvement plan or should it be separate? A systemic risk assessment tool is for proactively identifying systemic risk and should inform the risk management plan. The assessment may be part of or an addendum to the risk management plan, but should be clearly delineated as such and include all components as required in the regulations. However, a provider's risk management plan may be a standalone risk management plan, or it may be integrated into the provider's overall quality improvement plan. Risk management plans and overall risk management programs should reflect the size of the organization, the population served, and any unique risk associated with the provider's business model. So, we received a question that said the company completes risk assessments at least quarterly. Are there any examples or guidance for the annual risk report? Yes, we include a sample for the risk management plan on the Office of Licensing website. We received a question that said, how often do the systemic risk assessments need to be completed? These need to be completed at least annually. Providers shall conduct systemic risk assessment reviews at least annually to identify and respond to practices, situations, and policies that should result in the risk that could result in the risk of harm to individuals receiving services. The risk assessment shall address at least the following: 1, the environment of care; 2, clinical assessment or reassessment processes; 3, staff competence and adequacy of staffing; 4, use of high-risk procedures, including seclusion and restraint; and 5, a review of serious incidents. So we received a comment that says, because we're all trying to work together, why are we currently doing a round 3 for DBHDS when everyone is trying to complete and get ready for annual inspections? It seems to be a duplication of the same work. We want to thank you for taking the time to express your concerns. We understand that there are other offices and agencies completing inspections as well in response to expectations outlined in the settlement agreement. The department continues to work on ways to reduce the burdens to providers, and your concern will be communicated to those working on this project. So once again, thank you for expressing your concern, and we will certainly circulate your feedback. We received a question that said, are the care concerns measured on a per individual basis or across the entire company? Are the 2 care concerns thresholds referring to an individual or to the provider as a whole? Care concerns are tracked by licensed service, not by individual. The report is found in CRIS under the individual care concern. Below is a list of the care concern thresholds the IMU will track through the incident management process. The first is multiple, and that would be 2 or more unplanned hospital visits for a serious incident, which would include falling, choking, urinary tract infection, aspiration pneumonia, dehydration, or seizures within 90-day time frame for any reason. And the second would be any incident of a decubitus ulcer diagnosed by a medical professional, an increase in severity of a previously diagnosed decubitus ulcer, or diagnosis of a bowel obstruction by, which would be diagnosed by a medical professional. We received a question that says, when the supervisor or the person responsible for the risk management function, the supervisor of the person responsible for the risk management function signs the attestation, are they attesting that they have reviewed the document signed by the risk manager, or does their signature mean that the supervisor has also attended the various trainings? Only the person responsible for the risk management function needs to attend the trainings, and the supervisor is simply attesting to the fact that the person has completed the training, that they've reviewed the form, and that the person has completed the training. So there are no requirements for the supervisor to attend the training, only to review the form and attest to the fact that the risk manager attended the training. We received a question that said, should the agency have a separate risk manager for each service provided, or one risk manager for all services? The regulatory requirement is that the provider have a person designated by the provider to be responsible for the risk management function. This person may oversee other persons who carry out risk management activities, but is the designated person who is ultimately responsible for the function. Each licensed service is required to designate a qualified person with the responsibility for the risk management function. The provider may assign additional roles related to risk management, depending on the size and scope of the services of the provider. We received a question that said, how do providers receive feedback regarding the identified issues noted? The reason for the question is that it may be helpful if providers knew especially what their identified issues are as it applies to regulations. So of course, providers may reach out to their licensing specialist to ask questions and seek regulatory technical assistance. In addition, an exit interview should occur as part of the annual inspections, and this provides an opportunity to discuss areas of non-compliance as well as recommendations for coming into compliance with these regulations. We received a question that said, when will there be a training on changes with the MCOs? A lot of providers are struggling with all of the change. Thank you for your question. For questions related to MCOs, we would recommend that you contact DMAS or your MCO to request training regarding changes that have been occurring. So for any questions related to MCO training, we would recommend that you reach out to DMAS or the MCOs directly. Someone asked if this training provides a certificate. No, this training does not provide a certificate. Someone asked if we could post the direct link to the resources page. When we send out a copy of this training this afternoon, it will include a direct link to the resources page. Someone said, when we have questions regarding some of the topics presented today, who is a good contact person? Many times I've called to try and get questions answered and not been able to get a hold of someone. Please contact your specialist for questions related to regulatory compliance. So that would be your assigned licensing specialist. The list of staff and their supervisors are posted on the Office of Licensing website under Office of Licensing contact information. We received a question that said, can you briefly explain the key differences between risk management plan versus quality improvement plan? A quality improvement plan is a detailed work plan developed by a provider that defines steps the provider will take to review the quality of services it provides and to manage initiatives to improve quality. A quality improvement plan consists of systemic and continuous actions that lead to measurable improvement in the services, supports, and health status of the individuals receiving services. A quality improvement plan includes measurable goals and objectives, as well as progress towards meeting these goals. A written risk management plan focuses on identifying, monitoring, reducing, and minimizing risk of harms and risk of harms through a continuous comprehensive approach. The risk management plan should include identifying year-over trends and patterns and the use of baseline data to assess the effectiveness of risk management systems. We received a question that said, is the root cause analysis supposed to be done monthly, every quarter, or yearly? The root cause analysis should be done pursuant to the provider's policy. And a root cause analysis to identify systemic issues shall be done as determined by the organization. We're going to take another question or two. Any questions that were not answered in this training, we will, of course, provide answers in writing. We received a question that said, how do we get credit for attending this training? Do we keep our registration form? This webinar is being offered to providers as an update of the inspections that were conducted in 2021 and to provide additional clarification. This is not a training that will need any sort of certification or evidence of credit. So going back to risk management training, we have received a question that says, once the attestation is completed, will providers receive a certificate, and how will DBHDS know that the provider participated in the training? The provider is attesting to the fact that they did the training. There are no certificates. Providers of DD services may take the CDDER online courses, which upon successful completion will result in a certificate, but that is not a requirement for the successful completion of the attestation. Someone says, where do we send the completed attestation? There's no need to send the completed attestation. The provider should keep a copy of the attestation on file, and the licensing specialist will request the attestation. The attestation should be kept in the risk manager's personnel file. Someone said, looking at the attestation, what is there is looking, I think it's looking at the old attestation, no human rights is included. What do we do? Is conducting investigations referring to the human rights training, please advise. The Office of Human Rights has a YouTube video related to conducting investigations, and the link to this has been included within the attestation form. So that is going to conclude the question and answer section for this presentation. We thank you all for being here. And as we said, we will be sending around a copy of this presentation later today. And we will also be posting a copy on the Office of Licensing website. I cannot encourage you enough. If you have not signed up to receive our constant contacts, please go to the chat, the link in the chat, and you will be able to sign up for constant contacts. So you will get invitations to the trainings and to important memos that the Office of Licensing sends out. And also we encourage you to please share that link with any of your coworkers or your peers as well, if they have not signed up to receive our constant contact notifications. Once again, thank you all so much.